Asthma is a chronic inflammatory airway disease characterized by reversible airway obstruction, bronchial hyperresponsiveness, and episodic symptoms such as wheezing, dyspnea, cough, and chest tightness. It is one of the most common conditions managed in primary care. Epidemiology: asthma affects 8 to 10% of the U.S. population. It is more common in children, but persists or develops in adults. There is a higher prevalence in urban areas, with increased incidence among African Americans and Hispanic populations. Pathophysiology. The classic symptoms of asthma are wheezing, high-pitched and expiratory, coughing, which can get worse at night or in the early morning, dyspnea, which can get exacerbated with exertion, and chest tightness. Clinical presentation: the common triggers for asthma are allergens such as dust mites, pollen, pet dander, and mold, irritants such as smoke, strong odors, and air pollution, infections that affect the upper respiratory system. Finally, medications such as NSAIDs, aspirin, and beta. Diagnosis in primary care: history and physical exam. The first part of any exam and evaluation is to take a complete history and physical exam. For asthma, you need to ask about symptom patterns. Is it worse at night? Are there seasonal variations? Is it triggered by exercise or cold air? Is there a family history of asthma or atopy, such as eczema or allergic rhinitis? As the provider, you can examine your patient for wheezing, prolonged expiratory phase, nasal congestion, or eczema. Diagnostic test: spirometry is considered to be the gold standard to diagnosing asthma. The FEV1, FEC should be less than 70%, with reversible obstruction that has a greater than 12% increase in FEV1 after To confirm the diagnosis, 5:1 equals forced expiratory volume in 1 second. A low FEV1 suggests a patient has a breathing obstruction. FVC equals forced vital capacity is a measurement that shows the amount of air a person can forcefully and quickly exhale after taking a deep breath. Peak expiratory flow monitoring is useful for home monitoring and assessing exacerbations. Methicillin challenge test is used when spirometry is inconclusive. It confirms bronchial hyperresponsiveness. Allergy testing should be considered in patients with allergic triggers. Asthma classifications: intermittent asthma has symptoms less than 2 days a week, awakens the individual less than 2 times a month, and requires the use of a SABA less than 2 days a week, and the FEV1 will be greater than 80%. Mild persistent asthma has symptoms more than 2 days a week, can awaken the patient 3 to 4 times a month, and requires the use of a SABA more than 2 days a week, and the FEV1 will be less than 80%. Moderate persistent asthma will have symptoms daily, and awaken the patient more than once a week, and require SABA use daily. Their FEV1 will be 60 to 80%. Severe persistent ASTA has symptoms throughout the day. It can awaken the patient frequently, with the use of SABA several times per day. FEV1 is going to be less than 60%. Management in primary care: asthma is treated with a stepwise approach. Step 1. Intermittent. The patient should carry a SABA as needed, such as albuterol or no daily controller is needed. Step 2. Mild, persistent asthma. Use a low-dose, inhaled corticosteroids, such as budesonide. This patient should also carry a SABA inhaler as needed. Step 3. Moderate, persistent asthma. The patient should use low-dose ICS and LABA, such as salmeterol or Alternatively, they may use a medium-dose ICE alone, depending on severity and frequency of symptoms. Step 4. Severe, persistent asthma. The patient should use a medium high-dose. As the provider, you may also consider adding a leukotriene receptor antagonist, such as Step 5 to 6. Severe refractory asthma. The patient should have a high-dose ICS, ALA-A inhaler, and oral steroids. The provider should consider biologic therapies such as omalizumab for allergic asthma or mepolizumab for eosin. Rescue treatment should consist of using short-acting beta agonists for acute symptoms. Avoid overuse. Frequent SABA use, which is greater than 2 times per week, indicates poor control of asthma symptoms, and the provider should move to the next step-up therapy. Acute exacerbations. The signs of a severe attack include an inability to speak in full sentences, the use of accessory muscles, and nasal flaring. Finally, silent chest. If the provider listens to the patient's chest and cannot hear any sounds, this is an emergency, and you should call 911. Silent chest is an indicator of impending respiratory failure. Management in primary care or urgent care: oxygen if SpO2 is less than 92% nebulizer, with albuterol plus ipratropium, oral prednisone, 40 to 60 mg x, 5 to 7 days. Assess for ED, A referral PEF less than 50% of predicted no response to initial treatment cyanosis or altered mental status, special considerations, asthma in children. ICS is the first-line treatment for persistent asthma. The provider should avoid long-term oral steroids due to concerns with impeding growth and development. Exercise-induced asthma. Educate the patient to pre-treat with SABA 15 to 30 minutes before exercise. They can use ICS or montelukast for prevention. Asthma in pregnancy. ICS is the safest first-line treatment. For pregnant patients, avoid the use of LABAs. Occupational asthma. This should be considered for patients with symptoms that improve during the weekends or on vacation. These individuals generally are exposed to triggers in the workplace. When to refer to pulmonology, the provider should refer the patient to pulmonology if they have frequent exacerbations despite ICS therapy. If the patient has unclear diagnosis, such as possible COPD, overlapping symptoms. If the patient has severe or steroid-dependent asthma requiring biologic therapy. If there is a need for advanced pulmonary function testing. Key takeaways for primary care. Diagnose with spirometry. Look for reversible obstruction. ICS are the cornerstone of long-term management. Frequent SABA use signals poor control. Step-up therapy. Acute exacerbations require steroids, plus refer severe or refractory cases to pulmonology. Asthma medications. Quick relief medications. Levodopa, similar side effects to albuterol, but may cause less tremor. Long-acting beta. Formoterol. Side effects include tremor, headache, and palpitations. Someterol. Common side effects are similar to inhaled corticosteroids, fluticasone. Possible side effects include oral thrush, hoarseness, and cough. Budesonide may cause oral thrush and hoarseness. Combination medications, fluticasone, budesonide, formoterol. Similar side effects as Advair. Oral corticosteroids. Mood changes, increased appetite, and osteoporosis with long-term use. Leukotriene modifiers, montelukast. Possible side effects include headache, abdominal pain, and behavioral changes in children. Mast cell stabilizers. Cromolyn sodium. Side effects are generally mild and can include throat irritation and cough. Monoclonal antibody. Methylxanthines, theophylline. Headache, insomnia, and potentially serious cardiac arrhythmias at higher doses. Combination medications, indacaterol. Constipation and urinary retention. Each category and medication have specific benefits and considerations, so it's essential to discuss any concerns or new symptoms with a healthcare provider.